Good afternoon and welcome to HealthSystemCIO.com All-Stars panel, Tackling the Patient ID Problem, produced in partnership with CHIME, a complimentary webinar from HealthSystemCIO.com, sponsored by Imprivata. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We encourage you to ask questions during the event. You can type them in at any time in the lower right-hand corner of your screen in the Q&A box. Leave the default set to all panelists. We'll take those later in the program, but again, you can type them in as they occur to you. You can download the deck using the URL on your screen, and we've also got a shortened URL at the bottom of each slide. And we are recording today's event, so we'll have an archive ready within 2 business days, if not sooner, and you will receive an email when it's ready. Just so you see how we're going to spend our time today, first we're going to have about a 30-minute discussion on our topic with our panel, made up of Russ Branzell, President and CEO of CHIME, Keith Friedenberg, EVP and Chief Strategy Officer with CHIME, and Liz Johnson, CIO of Acute Care Hospitals and Applied Clinical Informatics with Tenet Healthcare. Then we're going to hear from our sponsor, represented by Justina Evliadis and David Weiner. And then we're going to have our Q&A. And we want to thank Imprivata again for sponsoring this event. So without further delay, I would like to begin our panel discussion. And I want to start off by getting a quick overview from the organizations, from our speakers. So Russ, do you want to kick us off by giving a brief overview of CHIME?
Absolutely. Thank you very much, Anthony. CHIME is the College of Healthcare Information Management Executives, and we are the professional association for over 1,800 CIOs and additionally 160 industry partners. Those industry partners represent a significant variety of our vendor community, but most importantly, they're the ones that are helping us to achieve some of the great standards and achievements in HIT adoption across the country. In addition, we represent 3 or 4 other associations, actually 4, that include over 1,000 additional healthcare executives in the areas of security, technology, as well as application support, and those are the ones traditionally reporting to the CIOs. And so we represent the association, including our vendor partners, that are responsible and charged with adopting technology across the country. So thank you very much, Anthony.
Excellent. Liz, you want to give us an overview of Tenet?
Absolutely. Thank you, and welcome, everyone. We're really looking forward to having this discussion. This is very important to Tenet. We're a big place, and to sort of get a sense of why we care about our patients being identified correctly, we do about 20-plus million patient encounters a year. We have 22,000 licensed beds, and 80% of our hospitals are now participating in ACO, so our data needs to be shared effectively among others outside of our immediate walls. We have 84 hospitals and 20 short-stay surgical hospitals, 470-plus outpatient clinics, 9 facilities in the UK, and 130,000 employees. So you think about the breadth and depth of us crossing across 24 states and our need to be able to be effective in healthcare. This is a subject that's near and dear to our hearts.
Excellent. Thank you very much for that. Now we're going to start off with you, Liz, and we're going to get a little deeper into the core issues. Now, everyone agrees that not having a unique identifier for every individual raises the probability of a patient being misidentified, as well as prohibits interoperability of patient records across organizations and makes matching very difficult. So let's talk about each of these and the consequences that result from them.
Glad to do that. So when you think about misidentification, which is obviously identifying the wrong patient, you're going to significantly contribute to adverse events across the United States. And why is that? Because if you're treating one patient using the information on another, you very likely could have a situation where you're not doing the appropriate treatment, and that's something we need to eliminate from our healthcare delivery. The second problem is that you get duplication because you create a new ID when one already exists. And when that happens, then you don't have transparency into other information that may be available because it's under another ID for the same patient. And then finally, you really can't create a true continuum of care, one in which we are delivering care across all the episodes and settings which we're expected to do today, because we don't have a single record. We have no way to identify clearly across multiple settings, and we misidentify and can't finish that continuum in a very real way, in a very necessary way, which puts our patients at risk. Another problem that we run into is around privacy. If you link the wrong patient information to them, then you potentially are exposing the information about another patient to that patient or those caregivers, and vice versa. If my information is not the right information, then I'm going to potentially give wrong disclosure or wrongful a violation thereof and create a privacy issue that's very, very real. So again, it's critical that we merge that information associated with the right patient. And then the final problem, I think, is really about the expense. It's very expensive. In 2015, Intermountain reported that every time that we have a duplication problem or a misidentification, it costs $60 to correct. If you think about that, in an organization like ours or others, it could be 10 times that much to correct it. So we're not just creating risk to the patients, which is the most critical component, but we're actually costing ourselves administratively, relating in delayed care, you know, larger denominations of duplicates and so on. And what we found clearly is that the duplication problem can be as high as 18 to 20%, even with a quote-unquote master patient index. So I know others on the panel may want to add to those points, but that's what I think about immediately when I think about misidentification.
I had one question based on what you were saying. Accidental release or disclosure of information, if it comes up because of a matching issue, is that not as serious under the law as if there was intent, if someone was snooping per se? Are you in just as much trouble if you had no intent to share it but it was a mistake?
I'll give you from experience what my answer to that, and then I would ask Russ and Keith as well. We always operate under the assumption that ignorance is not defense, and so so that means quite clearly that certainly wrongful doing or intent has not just, you know, ramifications under federal law, but there's also civil penalties that could come into place as well. But the reality of it is we operate under the perspective that if we've given out the information, which is why people are hospital care providers are so careful about identifying the persons and trying to get the right information to them, even beyond the malice that you described.
Very good. Okay, Russ, let's talk about some of these more specific issues. You have the idea of false positives, you have false negatives. You can read what they are on the screen, of course you know. Do you know how prevalent this problem is? Any sort of statistics or numbers or general thoughts around that issue?
Yeah, there's been several studies, including one out of ONC that's looked at this. We did some of our own statistical analysis several years ago, and unfortunately, it's extremely prevalent. Matter of fact, one of the best in the country that was mentioned by Liz earlier, Intermountain, did their analysis, found that their misidentification rate inside on a standard record with standard patient identification was up in the 5% range, and that's some of the best numbers we've heard in the country, is 5% for internal identification in that process. The numbers external to that, and actually even internal, what we're hearing is numbers far worse than that is the general norm across the country. Anywhere, as Liz put it, up to 20% for internal misidentification, meaning the environment in which you control a organization in its totality have still that high of a misidentification rate. Now, the part that's even scarier to that is the numbers that we're hearing external. When you're exchanging with partners that are not part of your confined health system, IDN, whatever the case may be, we hear of numbers even as high as 50 to 60% misidentification, meaning whether it's the wrong patient and the wrong information being brought into a record, whether that be done through an exchange or a point-to-point exchange with another provider in the community, whatever the case may be, it's the right patient in the instance that you're working on this patient, but that is matched with a wrong patient out there and the wrong information comes in. You know, that's kind of the concept of a false positive, meaning we think it's the right person and we bring that back in. What we're also hearing is just as high in alarming rates is when we go out to look for the right patient and get the critical information for that individual. It's the right patient, but no information is shown available for that. So information is not being fed in. Something as critical as allergies or drug lists, problem lists, especially when you start having patients come into ED where there might be mental health issues, behavioral issues that are out there that you want that information to flow. And that's one of the greatest challenges is are these still these silos and pockets of information that are out there. And it's pretty prevalent. With that being said, there's just an alarming amount of issues that are out there when you consider that most patient care is still generally local, meaning to a defined region, usually to some level of tertiary center in a larger urban area. So that's kind of the flow of patients in and out. But nowadays, what we're seeing is patients moving geographically across this country at a much greater rate than they were a few years ago, especially with the choices they have with health insurance and portability. Patients are moving across the country. In almost those cases, what you're basically seeing is almost an individual ability for that person to take their record with them because there's almost zero ability to match and exchange that information up. Rare examples where it does work, but in most cases, that's a case where it's all incumbent on the person, usually to carry either an electronic version on a disk, on a drive, or a paper version. And this is actually even fairly recently. With all the advances we've made on electronics and adoption of EMRs, we're still in that kind of environment. I think the real issue is what it leads to, and Liz mentioned this quite a bit earlier, and we're really concerned about this, and that is, first and foremost, the safety issues that are there. In one of our studies that we did internal to CHIME, up to 20% of the CIO respondents mentioned that a significant event, sentinel event, meaning significant harm, injury, or death occurred due to a misidentification within their health system over about a 2-year period of time. That's pretty alarming when you consider that. Could you imagine any other industry in our American economy where we'd say that's okay? If that even happened for a fraction of that on an airline or an automobile, they'd be grounded immediately. You wouldn't be able to get in one, or there'd be a complete recall. And that's, again, those numbers are still fairly consistent as of most recently. I think the other issue is how can we enable quality if we can't aggregate the data as much as we should, because the information's not being aggregated as well as it can. And I think the part that those should be the foremost reason we're doing this, the safety and quality and the care for the American citizens. But I think the part that's just as alarming is the impact it's having on our economy. Liz mentioned one number that's out there, and that was just one health system, when they did a review of duplicate records, when they added up the cost, just the human cost of deduplicating those records, it was about $5 million a year. So if you even pull back to that, to about 20% of that cost, and you just said on an average hospital, some are huge, some are small, some are really tiny, let's just say the average cost of that, if you added up all the cost, internal process, delays, red tape, all that kind of stuff, let's just say it was $1 million per hospital. That means that this cost in the United States is over a $5 billion problem to our economy with zero benefit. This isn't like we've created cost because we want to have benefit over on this side. It's like an investment. This is just waste. And there's no reason for us to have that. So I think what we're going to see is, as we move forward, an opportunity to not only have a big impact on our economy from a reduce of waste and cost, but most importantly, we're going to have an opportunity to really improve safety and quality.
Very good. Liz, when we talk about these costs, the duplicate testing and creating new records, are we also taking into account additional tests being ordered because we don't trust a record that may or may not match the patient in front of us? So a clinician just says, listen, I don't know if that's this guy, so let's just have another scan, let's do another this, let's do another that.
It's a great question, Anthony. I think that there certainly would be costs associated with duplicates because of lack of confidence, but I would tell you that we're not tracking that at this point. We are certainly tracking duplicate tests, and we have enough alerting in our systems to at least call to question for the sake of the patient. Do you need another radiology procedure taking place? Do you need another lab drawn? So on and so forth. I think that you've hit on a very critical point that if it's a trust issue, what we're finding is there's more trust problems created by the fact that the data doesn't make sense. So in essence, you get back to the same problem. So I'm reviewing the clinical record of a patient, and I see a finding that doesn't make sense to me, which is sometimes how we identify that the finding was not associated with the patient that's being cared for at this point. And then we go back and do ask the question. But we do not have a direct correlation, at least studied and actually documented in that area, although I think it raises a clear question for the future. And as we continue to move forward, should we be measuring that and presenting that information in a different way to our clinicians as they make decisions?
Very good. All right, I want to bring Keith in here. Keith, let's talk about a little bit about how we got here. We know there are things in place, there are prohibitions in place that have caused everything to stagnate and not move along as it should with the development of electronic records and a solution to be developed along with it. So tell me what's going on around that.
Absolutely. Thanks, Anthony. So when we have discussions with stakeholders about the size of this challenge and the issue of patient identification, as Liz and Russ have shared the costs and the patient safety issues, a very common question we hear back, is if the challenge is so great, why hasn't the federal government stepped in to solve this? And the reason for that is technically they can't. They're prohibited by law. So I'll take us back in time a little bit to 1996 when HIPAA was enacted. It actually required HHS to develop a unique identifier for healthcare. It's very specific. Unfortunately, before that could be achieved, the Omnibus Appropriations Act was signed into law in 1999, 3 years later. And within that act, it included a very specific provision that prohibited funds from being used to adopt any final standard providing for a unique health identifier for an individual until legislation is enacted specifically approving a standard. So what does this all mean without diving too deep into the language? What it means is that act, the Omnibus Appropriations Act, effectively precluded the federal government and HHS from spending any public dollars on developing a unique patient identifier. And that language has been carried forward in every single labor appropriations bill since, and it still stands today. So, of course, 1999 was a long time ago, and we all know that since then, and that restriction has been put in place, health IT has made tremendous progress in providing clinical care and enhancing patient safety outcomes, controlling costs, et cetera. But we also know from CHIME members who are out in the field that the lack of an MPI solution has become a major barrier to achieving the full benefits of health IT. Again, Liz and Russ gave great examples of some of those challenges. We also know, though, that matching the right patient with the right data is critical to ensuring patient safety and achieving all of the benefits that our industry is aiming to achieve. So that is why CHIME has been working so hard to address this legislative barrier. In fact, this has been top advocacy and public policy priority for CHIME for a number of years. We have mentioned the ban in just about every legislative comment we've written over the past several years since we had a public policy team established in DC. And I would say arguably even before other organizations were comfortable talking about removing that ban. More recently, we worked last year with the Sons of Congress language that was ultimately included in the 21st Century Cures Act, which cited the right of patients to have confidence in their information and that their record actually belongs to them. So it was sort of a roundabout way of getting at patient identification, but that's what it was intended to speak to. And more recently, we worked with the Senate Health Committee to insert language in a recent request to the GAO to evaluate the current state of patient identification and patient matching and look at the opportunities to improve both. And we also continue to work, on the grassroots front. We work with our CHIME members and their organizations and offices to request the removal of this ban and annual appropriations wish lists, if you will, that are submitted to various committees in both the House and the Senate. And this is an ongoing education effort, and we're going to continue that work. We also work with a number of other partner organizations. You probably heard of AHIMA's recent activity around a petition drive. Right now they're petitioning the White House to step in. And we're also leading, along with HIMSS, a much broader stakeholder group to address this issue. So we're definitely committed to moving this issue in the industry forward, which is why CHIME did step up and develop and launch the $1 Million National Patient Identification Challenge with HeroX earlier this year. And I know we'll have a chance to talk a bit more about that. But the good news is, on the legislative front, we are seeing a shift in sentiment in D.C. As an example, ONC recognizes that patient identification is an issue. They recognize it specifically in their interoperability roadmap, as well as a 2014 report specific to patient matching and patient identification. And ONC has been very supportive of private sector initiatives like ours to address the issue. So we are seeing a shift in that sentiment.
Excellent. Thank you so much, Keith. Liz, let's bring you back in here. Keith talked a lot about the policy issues and things like that. Anything else you want to add around the logistical and technical issues that that make this such a challenge?
Absolutely. To my colleagues on the phone, I mean, obviously we all have a great deal of passion about this because we see the critical need to do this right and to do it soon. And to overcome both the federal ban in terms of their prohibition as well as just our logistical issues. This is not easy. We have to identify patients accurately at the front end of their care every time, and we cannot do that today. There is no single solution. We use algorithms, we use all kinds of things to try and get to the right patient, but the reality is there is not a universal buy-in or single identifier that's available to us. We have to agree on how that will be available to us, what the data fields that will be required for matching, what will be in the information within those fields, and how we're going to collect that data. For those of us who work in the healthcare industry, and I think everybody that's engaged in this call must have a piece of that, think about the reality of what we deal in a registration area or in an emergency room or wherever your entrance into the care system might be. The persons who are registering you and trying to identify you, or even in the field, are taking shortcuts because they need to quickly get you into the system. And if you watch and you know how we all use our computer systems today, we often go to the default status. So if I ask you 2 questions and I get a match, very frequently then I move that process right ahead, and that's the critical information that's associated with you. If we have a clear identifier and a way to give that information to where we get our health care, we could achieve 2 things. One, you would know that you're actually dealing with the same Liz Johnson that's sitting in front of you or on a stretcher or wherever I may be in the system, and the information associated with them would actually be the information that had to do with me. So the logistics are very hard, and again, we have to agree these are the identifying elements that we're going to use. And, you know, we all worry about the privacy issues around name and date of birth and geographical location, and I can go on and on to the various demographics that we use, but we don't have agreement. And even the algorithms that we use do not agree and do not have the same amount of reliability because the data that went in the first place was not the same hospital to hospital, clinic to clinic, doctor's office to doctor's office, and all the other settings. The second thing is that the technology, as part of the logistics, has to actually be able to be built, affordable, and available. And today we buy algorithms and those sort of things, but they are not universal and they are not based on the same elements, so we must have a standard. In order to hold our partners in technology and take advantage of new technology, we have to be able to do that, which leads us back to policy, which if we haven't established and agreed upon a mandated standard, we won't ever get to the place where we're able to truly have an MPI that's used. This is hard, but you know, one thing I think the reasons that we've taken on the HeroX and really said it is hard, and the federal government can't be involved at this point, but we have an industry that is primed for this and knows that not identifying the patient at this point is more risk to the patient and to our economy than just going ahead and making that leap.
Right, right. Very good, very good. Russ, let's talk about proposed solutions. We certainly have illustrated the problem, but and obviously you've got your efforts, but thoughts around solutions.
Well, there's a lot of different things that can be done. Obviously, we'll talk specifically about what we're trying to do and facilitate in the industry. But what we are seeing is, as Keith mentioned, we're starting to see a lot more openness, at least at a federal government level, to remove the prohibitions in place that might accelerate either an adoption to or maybe even contributing towards some form of solution at a federated level. We think that will take a while. It's probably, at best, even if they acted very quickly, you're talking several years out, if not longer than that, for them to activate something in process for there. So we're not going to slow down on our actions. There's lots of people working on this very hard across the entire industry. We don't say this isn't for a lack of effort, but maybe from a lack of coordination and standards, as mentioned by Liz. What we are seeing, and we launched the challenge that Keith mentioned through the HeroX Foundation. We launched it officially in January, but we've been working on it for quite a while longer than that, to put a challenge out there to find a universal patient identification solution across the country. And we make it very clear that we use those words. We don't say this is an identifier. We don't say this is this or that or another thing. We just basically say we're looking for an identification solution that's effective and scalable to solve our problems at a nationalistic level. What we are seeing, though, is unbelievable interest in working on this, whether it be big or small. Even the largest multi-conglomerate organizations and companies in the world have registered for this. Some have. We've seen it all the way down to the young entrepreneur or the mom and pop working out of their garage. So it's in every scale in between. Probably stealing a little bit of Keith's thunder from more update, and that is, the most recent numbers. And I thought personally, if we could get 100 different organizations or individuals to compete in this, we would be wildly successful. What we are seeing now, and we only launched on January 19th, as I said, we're at 244 competitors, which is probably wrong by the time I mentioned this, and we just got the data a little while ago, representing 28 different countries across the world that want to participate in this process. We're seeing organizations come together as teams, meaning multiple organizations working on this collaboratively. They bring different parts of solutions together. And what we really are seeing is a lot of different ways people are trying to tackle and approach this, which I think is part of why we are here, and that is how do you bring all the pieces together. We're seeing people that have, or organizations that have very much technology-based solutions, things that include, we're not suggesting one versus the other, because that's what we're not doing in this process, is trying to solve it before we get through the process, that include things such as palm scanners and fingerprint readers. So there's a technology component. We're also seeing people come from a software perspective, meaning they've either written software that's inclusive of things like patient matching algorithms or other parts of registration systems or data compilation, those type of things, and that's one way of doing it. What we're also seeing is organizations that are suggesting or providing expansion of existing solutions in place, whether that's the Social Security system, which has all of its own trials and issues as well, plus its own prohibitions, as well as financial solutions, credit bureau solutions, other industries that have solved this in a unique way. So what we are doing is we go through this entire process, and we're expecting to see a lot more even to register, but more importantly, those that are part of the competition process, they will have to meet some pretty significant hurdles to this process, as we've defined very clear criteria, which are inclusive of some of the technical components, some of the scalability components, cost components, but also just as importantly, the privacy and security requirements that this country demands when you're dealing with something this important to individuals and something they hold so dear as their patient information and their identity. And so we're basically looking for a total solution that can really solve this. We are nowhere near there today, but we hope through this process we'll be ready to roll through this really going into early next year.
Very good. Keith, you want to add any more color? I know Russ admittedly stole some of your thunder, but if you want to add some more color around that, and specifically for our providers on the line today, like Liz, what do you want them to know about this process? And you want them to sort of, I would imagine, stay tuned and keep their ear open about the developments.
Absolutely. Thank you, Anthony. So a couple of things about the National Patient ID Challenge process that I think are important to share with the industry. One is that we spent about a year, a little more than a year, actually developing the criteria, the guidelines, and the rigor around the challenge. So we brought in about 36 subject matter experts from all across industry, multiple stakeholders, and tried to develop a 360-degree view of the challenge. And I'll admit, it took far longer than we thought it would to develop the rigor and the guidelines, but we knew ultimately that we needed to spend the time and do it right. So this was a tremendous amount of work that was done leading up to the launch that Russ referenced in January. Along the way, though, we realized that transparency in this process was going to be key to achieving industry and ultimately competitor buy-in. So at multiple points along the way, we took the work from the subject matter experts and the guidelines. We posted that out to the HeroX site. We crowdsourced feedback and input, and we did this iterative process a number of times until we ultimately finalized what we felt was very rigorous criteria. So I think it's important to share that, and I think that's part of what has to do with the excitement that we're seeing around the industry and, of course, with competitors, because if you go to the HeroX website and you read about the challenge itself, there's a great deal of information in detail that you can gather. As Russ mentioned, since launching the challenge, we've seen a tremendous outpouring of support from the industry as well as competitors. I won't rehash the numbers, but what I'll share is we're adding competitors. Right now, it looks like between 3 and 6 new registered competitors every day, which is unbelievable. It's certainly exceeded our expectations as well as our partner HeroX's. What I'd like to share about the challenge is it's actually being run in 2 phases. We're in the first phase of the challenge, which is called the Concept Blitz Round. Right now, what we're asking competitors to do is submit their concepts. Essentially, it's a 20-page paper requirement to tell us your idea around how you would solve this, whether it's technology or some other ideas. They don't have to ultimately submit the solution yet. This Concept Blitz Round opened in January. It will run through mid-April, and then we'll go through a judging phase, and then in mid-May, we will announce the top 3 concepts. At that point, what we will do is we will turn to opening the $1 million round, what we call the final innovation round. So around mid-May, competitors then can actually submit a solution. That process will remain open from May through approximately November, at which point we will close down the submission process so that our judges have several months to review the potential solutions that have been submitted. So we're early in the process. We've got a long way to go, but there's a great deal of energy and excitement around the competition, which is very encouraging. Let me also say that right now we're in the process of assembling our judging panel. I expect we'll be able to make an announcement via the HeroX website probably within the next week or 2 about who the judges are. I can just tell you that the judges will be folks that represent a broad cross-section of the industry. These are stakeholders. They represent health IT. They represent consumer interests, privacy interests, and, of course, security interests. So we're going to have a great group of judges who will help us through this process and ultimately help us achieve our goal, which is in early 2017, likely at CHIME Spring CIO Forum, we will announce the grand prize $1 million winning solution. That's our goal.
Excellent. Excellent. Well, I know you guys are putting a lot of work into this, so I'm sure the industry appreciates it. Liz, before we get to and hear from our sponsor, after which we'll take our audience Q&A, just want to ask you, you know, everything's a ways off, right? And a national patient solution identifier, as Russ said, is years off, if ever. Even the work that's being done right now with HeroX is at least a year off, sounds like a year off. Today, what is your advice to your colleagues who are struggling with this problem?
As CIOs, I think we all recognize in our leadership roles that this is not just a technology problem, and that as we're leading and looking to getting a national patient identifier and finding better technologies, we also need to bring our organizations back to recognize that people in process are equally engaged in both the solution as well as the problem we face today. So as you lead in your organization as a CIO, remember to bring people back to this is not something that we can just put some off-the-shelf, plug-and-play technology in place and we'll be solved. If we don't have the infrastructure around people and process, we won't be successful. I think another place where we play a huge role is around data. We are one of the most informed groups and understand the complexities of data and the impact of bad data. So again, I think we need to really promote the fact that we're going to need to continue to strive to clean up where bad data practices are in place, where we don't have data stewards, where people don't even recognize that taking the wrong birthday or having something in the record can actually create harm to our patients. So we need to continue to raise that level of awareness, not just as the leader of the information technology and informatics, but as a leader in our organizations from the role that we sit in. And then finally, I think we're all dealing with interoperability and the criticality of getting the information exchange. Every one of us has given examples of where it's not just inside of our walls, although that's a huge issue, but it's our ability to deliver care in our communities and in our nation. That interoperability is critical, and how do you move data around if we're not dealing with a patient identifier? We'll begin to look for how can we identify and move patients' data safely and lead in those efforts, because again, as a CIO, you are best equipped to understand what that means, what it will take, and give people a sense of real solutions, in other words, immediate solutions that are available today, but always keep your eye on that future of what is going to be available and how can we prepare ourselves so that we're first to be out there and making a safer place for our patients to receive care.
Excellent. Okay, great. Now, before we get to our audience Q&A, we're going to hear from our sponsor, who's represented by Justina Evliadis, Product Marketing Manager of Imprivata Patient Secure. And Justina has some relevant comments on the struggles we're talking about today. Justina, you have control of the deck.
Great, thank you. And again, we're very excited to sponsor today's webinar. Imprivata is very passionate about this topic of, patient identity and a unified patient identity, and we also provide some solutions in the space that we're going to share with you all today. But before we do that, let me just tell you, if you're not familiar with Imprivata, about our company mission and vision, and that is to enable healthcare to act. And by act, what we mean is enable clinicians and patients to access, communicate, and transact on their patient health information conveniently and securely. But in order to do that, the most critical thing is to properly identify the patient at the very beginning of the life cycle. And this was mentioned earlier in today's webinar. We're finding that 7 to 10% of patients are misidentified when their medical record is accessed, whether that's in registration or in other areas of the healthcare organization. And I believe it was Russ earlier in the webinar that mentioned, if there was harm to a person that happened due to, breakdown and processes in the automobile industry or in the airline industry, it would be completely shut down and all over the news. But yet we somehow accept these things to be true and exist in healthcare as it is today. So I think that was a great comment. But really what we're seeing from and hearing from our customers is that patient misidentification often results in duplicate medical records. So providers never truly have a full view of a patient's history and medical record. In addition, overlay records, Liz spoke about how dangerous those are earlier and how patients can suffer adverse events from having their information mixed with someone else's. And lastly, we're seeing a huge rise in identity theft and medical insurance fraud, and the inability to have that single layer of a patient identifier that's potentially mixed with biometrics really doesn't protect the health system or patients from this fraud. And as everyone mentioned earlier in the webinar today, that all ends up resulting in patient harm, such as adverse events from misidentification, loss of revenue, so that may be denied claims for hospitals or unnecessary duplicative testing, as well as unhappy patients who may be having, long waits in registration or even suffer from some of that harm. And I'd like to introduce David Weiner, our General Manager for the Imprivata Patient Secure Solution, to tell you about what our solution does to help alleviate some of these problems.
Thank you very much, Christina. So what the Patient Secure solution does is it creates a one-to-one match between the patient and their medical records through the use of biometrics. So the Patient Secure solution is seamlessly integrated as part of the registration workflow, which allows you to biometrically identify the patient at the time of care. So when the patient first enters the hospital and their record is brought up, we biometrically link that patient to their medical record. And on a return visit, we're able to use that biometric to positively identify the patient, bringing you directly to that patient record. So we've all heard about using probabilistic or deterministic kind of matching. We are actually matching directly to that individual. And with that matching, we're able to increase that patient safety by making sure we have that patient record each and every time. In addition, it allows us to positively identify that patient across an IDN. So anywhere within a healthcare organization, even if they have dissimilar systems, you're always going to that same single record for that individual. The Patient Secure solution is in over 65 healthcare systems, representing over 350 hospitals across the United States. And our customers have seen a drastic reduction in their duplicate medical records, as well as 100% reduction in their overlays. We have great partnerships with Cerner and McKesson. They actually offer our solution, as well as we're embedded in the Epic solution. And the key thing about the Patient Secure solution, because you have that single identifier for that individual, we're even able to positively identify the patient across institutions, because that single identifier is that consistent identifier between those organizations. So sometimes when people would ask how, for example, in like an HIE, how do I make sure I definitely have that patient record that allows me to move that patient's medical history between organizations? We're able to provide that single identifier between those organizations.
Great, David. And just a quick question came in here, so we can just take it now. How do you identity-proof patients before you link them to their biometric?
Well, today what we are using is we're using the existing infrastructures within organizations. So we actually do leverage the EMPI products that a lot of people use. So we do integrate in with like the Initiate solution or the NextGate solution or any of those EMPI solutions. So we are actually very complementary to those solutions. So you're able to identity proof that individual, allowing you to link to that medical record. And what our solution does is it allows you to really, allows those questionable situations to really bubble to the top. And is really brought to you front and center. And one thing I've neglected to mention is another key element is the ability to identify unconscious patients or unresponsive patients in that course of care. And we've heard from caregivers and clinicians that that is a great value added to the solution, as well as everything else it does.
All right, great. Thanks so much, David, for that. Just to wrap up with this last slide, a great article came out today over the wire about Carolina's healthcare system. You know, they were an organization that had about a 7% duplicate medical record rate. They implemented an EMPI solution, which got them down to about 3 or 4%. And then they added biometrics with the Patient Secure solution as a complement to that. And today they are at a 0.11 duplicate medical record rate and have eliminated pretty much all of their overlays, which is significantly, you know, at the forefront of hospitals and where most hospitals are with this system. So we're very excited to be working with CHIME in this space and really be looking at the forefront of healthcare patient identification moving forward. Thanks, Anthony. That's all for us, and we can go to Q&A.
Excellent. Thank you, Justina, and thank you, David. I appreciate your sponsorship and your comments today. So we do have time for a few questions before we get going. Let me start with you, Liz. A question has come in, and you kind of touched on this. If you have local systems with poorly maintained or dirty MPIs, being accessed will only proliferate to all other systems. So again, the concept of propagating poor data in this area, your thoughts around that?
Yeah, it's a really good question. It is absolutely a problem that we deal with on a routine basis. I think what you have to do is go back to what I would call the basics, which is we have to do a better job around combining records, and we have to work hand in hand with our partners in health information management and really make sure that when we find a duplicate record that we are very, very deliberate in our combining of those records, and when we find bad data, that we get it removed and people appropriately notified, and we do that every day. Unfortunately, there is no magic pill for this. The sooner that we get identifiers that people use on a standard basis, we agree upon the data components that will be required to identify you as you, and then we combine those records, then that will begin to diminish the impact. But there's a reality that we have to face, and that is the caller had a very accurate point of view, which is it is a problem today. We're not going to have an immediate solution for it. So if you don't have processes in place to identify when it happens and then notify those that it has occurred immediately so that we don't negatively impact care, then that so to speak, pile of wrongly identified information will only increase to grow. I wish I had a better answer, but that is a real answer.
We'll take real, so appreciate that. I just want to get one more question in. Let's put this in front of Russ and Keith. Do you feel that any future solution to the problem will include identifying patients by who they are versus what they have or what they know? Any thoughts on that, Russ or Keith?
Well, I'll start, and Keith, feel free to add in or
Sure.
correct me as we go along there. So what we're trying to do at this point is not overly define anything through this process of an outcome. I think the answer could involve any of those answers, of those examples that were given, or even some examples of things that we haven't even thought of. And if there's anything that we've seen as we benchmarked other Hero X and X Prize solutions is that often what we think and know in the industry today, there are people from outside our industry that will look at things in a totally different way, and we may come up with something totally different than what we have. But with that being said, there is obviously things, Liz touched on some of this, that we need to get straight in our system and all of our data cleanliness, if you want to use that term, that we need to get in place that will make this process of identification a smoother transition. I would never say the word easier. Less difficult is probably the better way of putting this. But what we will see is multiple ways of addressing this through the solution submissions that come out over the next year. Keith?
Yeah, I'll just add, I think what we're getting at is an example of a potential use case. And we've challenged the competitors to develop a number of use cases from very simple to incredibly complex and address how their solution would handle those. So a very simple use case, of course, is you present at your primary care physician and you've got your insurance card and photo ID, et cetera, maybe they even know you. But what about if you present at an emergency room unconscious with no photo ID? And that does get to, I think, the question, which is, identifying an individual, a patient, if you will, in an environment or in a situation where you have to identify who they are, not based on what they have, like a photo ID, but based on other elements. Again, we don't know ultimately how the solutions will tackle these challenges, but what we want to do is let the innovators innovate. That's what we expect they'll do very well.
Excellent, excellent. Well, that's about all we had time for today. I want to go out of my way to thank CHIME for putting together that Hero X competition because, as they expressed, just putting together that competition is an amazing amount of work. I know I have difficulty putting together a 10-question survey. Speaking of which, when we close out of this event, you will have a survey pop up on your screen about our event today. If you could take a moment to answer that, we would appreciate it. I want to thank our panel, our good friends Russ Branzell, Keith Friedenberg, Liz Johnson. I want to thank Imprivata, represented by Justina and David, very much for sponsoring the event today. As I mentioned, you'll get an email when our archive has been posted to our YouTube channel. and you can check that out. For those of you who do have the CHIME CHCIO certification, attending our webinars gets you 1 CEU. So if you've asked us to let CHIME know, we will. If not, make sure you let them know that you've attended. Sponsorship opportunities, you can contact Nancy Wilcox, or if you need a certificate of attendance at today's event. And you can go to our website to view our upcoming schedule. So with that, I again want to thank our panel, our sponsor, our audience. Everybody have a wonderful day.
Thanks, Andy.